Olá, é com satisfação que recebemos a professora doutora Lynn McCleary em nosso 5º Congresso Internacional de Estudos do Envelhecimento Humano para apresentar a sua conferência intitulada Inovações para apoiar a vida e a morte em instituições de longa permanência. Seja bem-vinda. Professora Lynn McCleary é enfermeira, doutora em Serviço Social pela Universidade de Toronto, docente no Departamento de Enfermagem e diretora do Programa de Mestrado em Gerontologia Aplicada na Faculdade de Ciências Aplicadas da Saúde, na Universidade Brock, em St. Catharines, Ontário. Sua área de pesquisa está relacionada com cuidados com demência, cuidadores familiares, ensino de gerontologia e geriatria, saúde e serviços sociais. Hello, it is with satisfaction that we receive Professor McCleary in your 5th International Congress of Studies of Human Aging, to present her talk entitled Innovations to Support Living and Dying in Long-Term Care Homes. Be welcome. Professor McCleary is a nurse. She did her PhD in social work at the University of Toronto. She is professor in the nursing department and director of the Master of Applied Gerontology program in the Faculty of Applied Health Science at Brock University, St. Catharines, Ontario, Canada. Her research interests are related to dementia care, family caregiving, gerontology and geriatric education, and health and social service. Professor.
Thank you, Will. I'd like to begin with greetings from Brock University. This is a map of Canada, and Brock University is in Ontario, Canada, not far from Toronto, and very close to Niagara Falls. This is an aerial view of most of the campus, looking towards the city of St. Catharines and Lake Ontario. The university is located on a UNESCO Biosphere Reserve, and there are beautiful trails on the edge of campus. I also bring greetings from my faculty, the Faculty of Applied Health Sciences, and my home department, the Department of Nursing, where we have amazing nursing students. My faculty is also home to the Masters of Applied Gerontology program that I direct. I'm honored to be presenting at this Congress and sharing our research with you. I want to thank Dr. DeMarchi and Dr. Portella, and thank the University of Paso Fundo for partnering with me. This presentation is the result of a partnership that was supported by the Government of Canada Faculty Mobility for Partnership Building Program. I'm grateful to the Canadian government for recognizing and supporting our partnership. Today, I'm presenting research that is a result of 2 collaborations. I'm very fortunate to be a member of the SPA LTC research group led by Dr. Sharon Castlelainen from the School of Nursing at McMaster and Dr. Tamara Sussman in the School of Social Work at McGill University. The SPA research is a product of partnership between many researchers and research staff. My research staff at Brock were Lori Lewin-Stratui and Natalie Meisenberg, and we couldn't have done the research without them. I'm also grateful for the opportunity to work with Dr. Linda Garcia, Dr. Annie Robitaille, and research staff of the Revive project, Christine LaSalle, Stephanie Blay, and Christine Holmes. Finally, I want to acknowledge the agencies that funded this research: the Canadian Institutes of Health Research, the Canadian Frailty Network, and Health Canada were major funders of the research I'm describing. We also received funding from the Alzheimer's Society of Canada and from provincial funding agencies in the Canadian provinces of Ontario, Manitoba, Alberta, and Saskatchewan, and from partner long-term care homes, and from Brock University. Theodore Levitt said, "Creativity is thinking up new things. Innovation is doing new things." I'm fortunate to work with people who have great ideas, and we're all blessed that we had the funding to move beyond thinking to innovation and doing, to innovate and test ways to improve lives of people who live in long-term care homes. Now, on to the innovations. I'm going to start with some background information for you about aging and long-term care homes in Canada. Then I'll describe 2 research programs that tested innovations to support quality of living and dying in long-term care homes. Brazil has so many more people than we do in Canada. Our population is about 37 million, and just over 17% of our population is seniors, people aged 65 and older. We have a higher proportion of older adults than children, and we're an aging population where the proportion of seniors is expected to grow. On average, a 65-year-old Canadian can expect to live another 19 to 22 years. Most older people in Canada live in their own homes, and some live with family members. Less than 10% of older adults live in some sort of a care home or congregate living arrangement. There are two kinds of congregate living or group housing for older adults in Canada. Retirement homes operate outside of the healthcare system, and people who live in them pay the full cost. They provide private rooms, meals, laundry, and cleaning, but nursing care isn't part of the typical service. People who live there can pay for additional care and can pay for nursing care, but most people who live in retirement homes don't have high needs for healthcare. Just over 3% of older Canadians live in a long-term care home. Long-term care homes, also known as nursing homes, operate within the healthcare system. They provide room and board and nursing care. They can be operated by private companies for profit, by nonprofit organizations and charities, or by local governments. Residents pay room and board costs, and healthcare costs are covered by the government. And there are government subsidies for people who cannot afford long-term care but need it. These are some images of long-term care homes. You'll notice that the residents typically have very high dependency and care needs and are among the old in the population. Most residents in long-term care homes are at least 85 years old. They have high care needs and typically multiple comorbid chronic health conditions. About 2/3 of residents have dementia and 90% have some sort of cognitive impairment. About 1/4 of residents have signs of depression, and just under half have limited or no social engagement. That's it for background information. This is Niagara Falls at sunset. This is my favorite place to view the falls, right at the edge. It's mesmerizing to watch. So the first innovation I'll tell you about is the REVIVE research program. REVIVE is a French word for revive, and this project was aimed at social revival for residents in long-term care homes. Alfred North Whitehead said about innovation, "Ideas won't keep. Something must be done about them." This project was about action. We had great ideas that we weren't able to act on until we found the perfect funding program from the Government of Canada. My colleagues and I had long been concerned about the social isolation of people living in long-term care homes. Several of us had parents who had dementia and lived in care homes near the end of their lives. So we not only knew the research, but we witnessed the challenges of social isolation, inadequate staffing, and funding for social engagement. In some cases, we hired extra staff to be with our family members, but that's not an option for most people. We knew that old and young people benefit from intergenerational exchange, and we thought that having young people volunteer to be with residents was a solution. We were able to test this out with funding from Health Canada. A little bit more background information for you. We have 2 official languages in Canada, English and French. And French speakers are a minority in Canada, especially in provinces like mine, where most people speak English. French and English speakers are entitled to receive health services in their language, but providing these services for people who speak French in areas where most people speak English is a challenge because there aren't enough French-speaking healthcare providers. So this means that the isolation challenge is even more for people who don't speak, whose first language isn't English. Health Canada wanted to encourage young French-speaking Canadians to consider a career in healthcare. And so that's where this funding came from, part of their work on increasing the availability of French services in healthcare. So we developed our program targeted at French-speaking residents of long-term care homes outside of Quebec in communities where French speakers are a minority. These slides are quotes from volunteers in our study, and they illustrate the problems residents face when they don't speak the majority language. This volunteer observed, once again, we had some problems with language. They had a piano recital today for Mother's Day, and the conversations that happen among residents are all in English. I could tell that Madame X stayed silent because she felt like she could not contribute to the conversation due to the fact that she doesn't understand them. This volunteer observed, this is in French, but I'll tell you what it is in English, and then someone else can tell you in Portuguese, maybe. But this volunteer observed the interaction with the nurse. She spoke only English during my resident's bath. My resident was very frustrated because she couldn't understand the nurse who spoke English. When the nurses speak English to my resident, I translate for her, and she is less fearful. This volunteer observed she avoids sitting in the TV room because she can't understand the shows being played, so she leaves to watch TV in her room in French. It seems like there should be an easy solution to this, but it's been a long-standing problem. The social isolation is a long-standing problem in long-term care homes, hence the need for innovation and action. Our objectives were to demonstrate the feasibility of our program, to educate students who want to pursue a career in healthcare about the importance of language and culture in long-term care, and to increase student interest in pursuing a healthcare career. We did this study in Ottawa, where a relatively large minority of the population speak French, and in Welland, a small city in the Niagara region, which is home to a minority French-speaking population. There were 5 long-term care homes, a French home in Welland, 2 French homes in Ottawa, an English home in Ottawa, and a home in Ottawa that provided bilingual services. Our volunteers were high school and university students. Each resident was paired with 2 students. The goal was that each student would visit the resident for 3 hours twice a week for 18 months. Thus, each resident received 4 visits from a youth volunteer every week. Training was provided for students at the beginning of the program and throughout the program. Data collection included surveys with information about the visit completed by students after each visit, focus groups with students, staff, and residents and/or family members near the end of the program, interviews with students about their experience, and data about resident quality of life was collected from the medical record. So we found that the program made a difference for residents, provided respite for the family, and was positive for students. Relationships between students and residents were the cornerstone of the volunteer experience. All students developed a meaningful connection with their resident, and they valued the relationship. The relationship played an important role in the ongoing motivation of students and the sustainability of the program. It wasn't essential to match students and residents based on their interests. Students and residents engaged in a large variety of recreational activities, such as conversing, playing games, going to organized activities, watching TV, and going for walks. Having conversations, visiting, and going for walks were the most common activities, and both the residents and the students really appreciated the opportunity to get outside, especially during the summer. Students generally found that they were fairly consistent from visit to visit with the kind of activities they engaged in. They found that residents' energy levels varied depending on the time of the day, and so they found ways to come to visit at the times when the resident would have a better energy level. And the students and family members reported that residents were happy during the visits. Students were able to overcome barriers to volunteering. They experienced some initial nervousness. They had training and support from the program coordinator, and this helped. And then early success with the visits helped with this. Ottawa is a large city and Niagara a more rural area. And some students in the Niagara area didn't live in the same city where the long-term care home was, and they needed rides from their parents to get to the the volunteering, whereas students in Ottawa, transportation wasn't as much of an issue because they had public transport, and as university students, they had free bus passes. Sometimes other commitments interfered with volunteering. However, the meaningful relationships motivated the students. They found it was easy to establish connections and true friendships. The mutuality in the relationship was important to them. As one student said, "We're good friends, and now it's funny. When in our debriefing, I go and tell them she's no longer a resident I visit, but she's my BFF, like best friends forever kind of thing." Students enjoyed the visits. They described them as a break from their everyday stresses. They said that they learned and applied new skills, including critical thinking, problem solving, and improving their communication skills. They developed confidence in themselves. They're able to reflect on what was important in life. Many of the university students were enrolled in science programs, and they really appreciated that this gave them an opportunity to have hands-on experience in healthcare and see whether they'd like to pursue a career in healthcare. They also appreciated the opportunity to interact with healthcare professionals and get to know what the jobs were. For students, it felt good to help people. For example, a student reported, "She's told me before that she hasn't played cards in like a really long time. And she tells me that. So it really gives her a chance to relive something that she's really liked playing in her life." Another explained, "I really like it. I like coming in and she just gets up and hugs me. And then it really makes me feel like, oh, I'm doing something to make a difference for once, right?" So this innovation was feasible. As planned, it counteracted social isolation for the residents. There were many benefits for the students and residents. It did require coordination for recruitment, matching, training, and ongoing support. If you're interested in more information, this is a reference for a paper published by one of our student research assistants. So that's the first innovation. And we'll take a break with another beautiful scene in Ontario. This is another place in Ontario that I love. It's the Elora Gorge, and this painting shows a tree thriving in the harsh environment of a rocky cliff. Sometimes that's what innovation is like, finding ways to thrive. The next innovation that I want to tell you about is the Strengthening a Palliative Approach in Long-Term Care, or SPA LTC program. I'll provide a bit of background information, describe the innovation model and our research program, and then a few of our findings. So as I previously described, most people who live in long-term care homes are very old with multiple comorbidities. They often move to long-term care homes when their care needs become too much to manage at home. Thus, it's not surprising that between 1/4 and half of residents of a long-term care home die every year. It's completely appropriate to use palliative approaches in care of residents in long-term care homes. The problem is that care for dying residents and families is not where we'd like it to be. There's a hesitance to discuss death and plan ahead. It's difficult to predict the illness trajectory and death of residents. Management of pain and other symptoms when someone is deteriorating or dying is suboptimal, especially when residents have dementia. And there are insufficient attention to loss, grief, and bereavement. Near death, treatments or transfers out of the long-term care home to the hospital happen too often. Tom Peters said about innovation, "Swipe from the best, then adapt." That's what my colleague, Dr. Sharon Castellanen, did. She's been working in this field for many years. She's developed the SPA LTC model based on testing her innovations and drawing on the best research available. There's no easy solution to the challenge of applying principles of palliative care and long-term care. It's complex. The SPA LTC innovation has 6 key elements. The foundation is the interdisciplinary champion team. They work together to plan and implement new practices and provide leadership and support to their colleagues. The team includes representatives from all of the kinds of staff in the long-term care home: healthcare aides, nurses, rehabilitation, recreation, pastoral care, social work, dietary, everyone involved in care. It's not just managers directing, but a team of champions leading. Supports for educating families and residents about what to expect at the end stages of common illnesses were created by developing education pamphlets I'll tell you a little bit more about. Residents are assessed for indicators of deterioration that may signal nearing death using the palliative performance scale. This is done close to admission whenever there's a change in condition and with quarterly assessments. This enables identification of potential for death so that a care plan can be modified. And palliative care conferences are held when residents have low scores on the palliative performance scale or staff are concerned about a change of condition. These are meetings between staff and family members that include discussion about end-of-life preferences and needs. And the last two components are comfort care rounds and post-bereavement follow-up. Comfort care rounds are meetings of clinical staff to plan care and discuss and debrief about a resident's death. They provide for learning among the staff as well as planning care for the resident. External experts such as palliative care consultant nurses participate in these rounds until internal leaders have enough expertise to facilitate them. Implementing the SPA LTC requires that it be priority of leadership and management in the homes. The champion team is essential. Changing practices involves education and training of staff, as well as review and revision of policies and procedures. Drawing on external expertise supports implementation. This is a large ongoing program of research, the SPA LTC research program. It started with pilot testing and refining the model in 4 long-term care homes in my province of Ontario, and then a mixed methods participatory action research study tested the model outside Ontario in 4 long-term care homes. And now we have funding to begin a pragmatic stepped wedge randomized controlled trial in 25 long-term care homes in 3 Canadian provinces. That study is on hold because of the pandemic, and we hope to start it in March. With some variation, the methods of these studies include enrolling residents and families of residents with low palliative performance scale scores, follow-up for a year, baseline and end of study focus groups, interviews and surveys with family members and staff, and focus groups with residents, as well as getting data from clinical records. In our initial testing, the long-term care homes were successful in implementing the palliative care conferences before death for 81% of residents who died. None of them, in the year prior to the study, no one was getting this kind of care conference, so that was a significant change. There was a 72% reduction in hospital deaths, with most residents dying in long-term care homes, and there was a 54% reduction in visits to the emergency department in the year before death. The palliative care conferences are key. That's where end-of-life preferences are revisited and families are engaged in planning for end-of-life care. Among families who attended the palliative care conferences, when they looked back after the resident died, there was a feeling that the care conferences helped them and the staff to be all on the same page, that it improved communication and working together. Families provided examples of ways that the care conferences promoted individualized and holistic care. And they said that it improved communication within the family and with staff. Among the families who did not attend the care conference, families reported that they thought they didn't need to attend the care conference. For example, if they were healthcare providers or because they visited the home frequently. Nonetheless, when they looked back after the resident died, they expressed wishes for better communication and that they needed more information to be better prepared. These are needs that could have been met with a care conference. Our first study identified a need for education for families about what to expect and about the illness trajectory of conditions that are common in long-term care home residents. Illness trajectory pamphlets were developed about 5 high prevalence conditions: dementia, advanced lung disease, advanced heart failure, advanced kidney disease, and frailty. The intent was that families could read the pamphlets and the information would encourage advanced care planning discussions. This is an example of one of the pamphlets. The pamphlets were used to educate families, and staff used them to get information as well. Access to the pamphlets encouraged residents and families to reflect about future care. It clarified what questions they should ask. It increased comfort in talking about end-of-life care. These were positive effects. We also found that it led to discussions between relatives and families, but less commonly, about 56% of the time people reported that. And less commonly, it led to conversations with healthcare providers about 40% of the time. In focus groups, we heard that reading the illness-specific information was validating, but that a tendency to protect one another or want to protect one another from the emotional topic of death prevented relatives and families from talking to each other about end of life. So thus moving to discussion would require staff support. Among the healthcare providers, registered staff, that's registered nurses, were more comfortable using the pamphlets than nursing assistants were. This is the website for the Canadian Hospice and Palliative Care Association. We have a section of the website devoted to information about the SPA LTC model project. The pamphlets are available at this website. These are some publications about the research. Our work to date illustrates that the SPA LTC is feasible and has had an impact on important aspects of end-of-life care. Back to Theodore Levitt, who said, creativity is thinking up new things, innovation is doing new things. The 2 examples I provided you with required thinking up new ways of providing care in long-term care and enacting these ideas. We were fortunate to have research funding to do new things and find out that they worked. Thank you. I'm so pleased to have been able to share this research with you. You can contact me by email, and more information about our publications is available on Google Scholar and ResearchGate.
Então, em nome dos docentes e discentes do Programa de Pós-Graduação em Envelhecimento Humano, da Comissão Organizadora do 5º Congresso Internacional de Estudos do Envelhecimento Humano, bem como em nome de todos os participantes do nosso congresso, agradecemos a sua valiosa participação. On behalf of the professors and students of the graduate program in human aging, the organization committee of the 5th International Congress of Studies of Human Aging, as well as in the name of all participants of our Congress, we thank you for your valuable participation.